Thank you, Shruti. I think we'll wait for maybe a couple of more minutes and then we will start at sharp 7. Good evening, everyone. And it's 7 p.m. now, and I think we will start the session. I would like to thank Dr. Venkatraman Radhakrishnan from Professor in Head Department of Medical Oncology for uh, Adyar Cancer Institute for moderating this session. And we have chosen two topics for today. So the first one will be presented by Dr. Anita Palat, who is a DM pediatric oncology resident from Tata Memorial Hospital, who will be discussing on eflornithine as post-immunotherapy maintenance in high-risk neuroblastoma, following which we'll have a brief discussion. And then Dr. Shivam Bansal from AIMS will be presenting the other paper on acute leukemia. So I would now invite Dr. Anita to please share her slide and start the presentation.
Thank you, sir. So is my screen visible?
Yes.
Good evening, everyone, and welcome to the journal review. The journal I've selected is DFMO as a post-immunotherapy maintenance in high-risk neuroblastoma. It's an externally controlled propensity score match survival outcome comparisons. To know this paper, we actually need to know two different trials. So here we are comparing two different trials, both from the COG group. So one is the ANBL 032 trial, where the dinutuximab was tried and established as a standard of care of therapy. And the second one is the DFMO trial per se. It is the NMTRC 03 trial. So both these trials are compared in the present paper, which we are discussing. It's a DFMO trial, which is a propensity score match survival outcome comparison. So for that, first we will need to understand a bit of the first trial, which is the ANBL 032 trial. So this is a trial which established dinutuximab as standard of care. So all the patients of high-risk neuroblastoma were given induction, consolidation with high-dose chemo and autologous stem cell transplant, followed by post-consolidation therapy with cis-retinoic acid alone, or it was randomized to cis-retinoic acid plus dinutuximab. And in this study, significant survival outcome difference was present. And then we understood that the standard of care as per the COG 0032 trial is dinutuximab should be given as a post-consolidation maintenance. Post-consolidation therapy, sorry. Now, with that trial, we did get a survival improvement. But why did we still go and do the DFMO trial? So that is a question. So for that, I should tell you that the COG data shows that the EFS at the start of immunotherapy was 66% at 2 years, but then it drops to 59% at 4 years. So there is a gap, or there is a significant drop in the outcome, the survival, between these 2 years. So we should understand there is a scope of a post-therapy maintenance, should be considered as an important strategy to improve survival in general. So that is the context of the DFMO trial. So DFMO is actually a irreversible inhibitor of the ODC. ODC per se is an NMYC regulated gene, and it is involved in the polyamine synthesis. So this is not only involved or not only used in neuroblastoma, it is used in different other conditions, other malignancies also. So in the NMTRC-003 trial, or the DFMO trial, which is a phase 2 single arm study, this evaluated DFMO as a maintenance therapy to prevent relapse. So they had given DFMO to 2 different strata of patients, and the subjects is divided into 2 strata, where stratum 1, which constituted only patients who were given upfront therapy, and the stratum 2 had patients where the patients had a refractory disease or any history of a previous relapse. So, but the catch here is that in the paper we are discussing, the stratum 2 patients are not per se considered. So this is the eligibility criteria for the stratum 1 and stratum 2, which is what I told. It is the upfront therapy patients and those patients where a refractory disease or relapse were there. Now, the DFMO dosing in the trial is 750 mg plus or minus 250 mg per meter square per dose. It was a twice a day dosing. It was a 28-day cycle, and such 27 cycles were given. So the total duration of therapy was 2 years, and DFMO was available as a 250 mg tablet. And initiation of DFMO was required within 120 days from the completion of previous therapy. So toxicity profile as elucidated in the trial, DFMO trial, is very minimal, and no significant or high-grade toxicity were there. The hearing loss, which is a known and specific side effect, was reversible, and no patient required a permanent cessation of the drug. Only interruptions were there. And thrombocytopenia is a known side effect, but it was not present in the study cohort, but because the dose used in this trial is actually very minimal compared to the actual dose used. So this was this is the concept diagram for the DFMO trial, where patients were allocated into stratum 1 and stratum 2, and they were followed up and analyzed. So the treatment, the patients included patients treated with COG protocol, MSKCC protocol, and even Sayatan protocol, and some other protocols as well. Now, the results of the NMTRC-003 trial, 101 subjects were enrolled to the stratum 1, and the 2-year EFS was 84% and the OS was 97%. 39 patients were there in the stratum 2 with a 2-year EFS of 54% and OS of 84%. And the toxicity profile, DFMO was well tolerated. Actually, 67% did not develop any adverse effect at all. The most common adverse event reported was transaminase elevation, and 76% had previous hearing loss at enrollment itself, and 4% had a worsening of that, but actually it required temporary holding of DFMO only. After that, the hearing actually came back to normal. So none required complete cessation of the drug. Now, in this trial, we understood that DFMO has survival benefit, but then why go a step further and do a complicated statistical analysis on the existing cohorts of patients? So the DFMO trial was a single arm study. It is a non-randomized study, and there is no control group. So the interpretation of results would be difficult without a bias. And from single arm studies, the quality of evidence we get is considered to be inferior to an RCT. And when we use historical comparison groups externally, there could be selection bias. Now, we had to find a method to bring a quality evidence which can be compared to an RCT. And RCT is difficult to be done in a setting where neuroblastoma itself is a rare disease. So here we compared two trials and two trials which actually occurred in different time points, and some overlapping time period was there. So all patients received induction, all patients received consolidation, and all patients received dinutuximab. In the ANBL 032, dinutuximab actually studied, and by the time the DFMO trial started, dinutuximab was already established as a standard of care. So all the patients received dinutuximab, and they were followed up in the ANBL 032, which served as sort of as a control arm. No patient received DFMO, and in the NMTRC 003 trial, patients received DFMO. So it served as a treatment arm, and the other arm 032 served as a control group. Now, how to make it equal? So the eligibility criteria and the exclusion criteria of these two trials are different. So we had to find a way to first eliminate those kind of selection biases and to sort of equalize the data. So selection rules were applied on both the cohort. So if you can see, the NMTRC 03 had a total of 141 patients. And the ANBL had a cohort had a 1,328 patients. So the eligibility criteria of each of these trials were applied on the opposite cohort and sort of equalized the data. So now let's see how that happened, and this is a sort of a tricky part. So this let us first understand how the DFMO trial equalized the data.
ക്ലാസ് ഞാൻ അങ്ങോട്ട് ചെന്നാൽ മതി.
Okay. So in the first group, let us see the 141 patient. First, we remove the patients not receiving transplant within 13 months of the diagnosis, because in the 032, the eligibility criteria was that the patient should be transplanted within 12 to 13 months. So they were excluded. Whoever did not receive transplant were excluded. Then the second is they remove patients not receiving rituximab within the 205 days from ACT, because that is also criteria included in this trial, in the 032 trial. Then remove patients who did not have less than PR in the pre-ACT response. In the DFMO trial, the patients were required to have a less than required to be in PR when they were enrolled. The enrollment was after dinutuximab. Okay, so here whoever was less than PR in the pre-bone marrow transplant evaluation, they were excluded from this study. Then finally, in this cohort, remove the patients who had history of prior relapses. So stratum 2 was not included here, and who were enrolled more than 120 days at the end of immunotherapy. So at the end of immunotherapy, if you could wait like 4 months to start the next therapy, the risk should not be that high is what they considered, and such comparatively lower risk patients were excluded. Now coming to the 032. So the first they removed the patients who were having active disease while enrollment. So those patients with some evidence of disease were removed. Then patients who had some event less than 30 days were enrolled, because the median time for enrollment in the DFMO trial was 31 days. So whoever had an event prior to that would not be an eligible candidate for DFMO. They were a part of this DFMO study. So those patients were also removed. Then I told that these two trials actually occurred in different time points, but then there was some overlap. So some of these patients who received dinutuximab as part of the 032 trial, they actually went on to be a part of the DFMO trial. So those 87 patients were actually would be common. So those patients were also excluded. So from the total number, the number came down to 852 patients in the no DFMO arm and 92 patients in the DFMO arm. So actually, it would have been easier to compare 92 with 852. That was not done. What we did compare between 852 patients and the 92 patients. But what was added additionally to this, that the new statistical method was done on it, which is called as a propensity matching. Now let us see what a propensity matching is. So propensity matching is what you do when you don't have, or we cannot run a randomized experiment, but then you have to understand, or you have to bring out a quality evidence to examine the effect of a given treatment to produce an outcome. So we have the propensity score that allows us to select the samples for observation that are balanced across the two different groups according to the confounding variables which you predict are the confounding variables. So let me make this a bit simple. I can give you an example. So we are trying to find out the evidence or the impact the smoking has on lung cancer. And we identify that there are a few confounding variables to it. Now we statistically assign and produce a score which is called as a propensity score to the control group and the treatment group. So each variable entered, or each patient will get a particular score or a propensity score, and whoever gets matched with the other group on that propensity score, they get selected for analysis. So whoever does not get a matching person on the other group, they get eliminated. Okay. So this is called as a nearest neighbor matching. To figuratively I can make it figuratively. It would be like all the patients in one trial and the other trial are added together, and whoever gets a matched pair, they only gets compared, and all the other patients who does not have a matched pair, they get eliminated and will not be taken for analysis. This is a 1:1 propensity score matching, which need not be the case. In our study, or the study we are discussing, it is not a 1:1 matching. They are a 3:1 matching. So for every one patient treated with DFMO, we'll have 3 patients not treated with DFMO on the other arm. So the steps, to simply put, the steps in propensity score matched analysis are these 4 steps. 1, we have to identify the confounding variables which you think can affect the treatment and the outcome. Then you estimate propensity score, which is a pure statistical method. Then you create matched sample using a propensity score. So again, whoever has a matched propensity score on the other arm, they get selected, and all the other patients who do not get a pair, they get eliminated. And run the analysis only on the matched sample. So analysis can be any of the statistical tests you want to do. Now, what are the advantages of this method? 1, it is a comparative study with a good quality evidence, which can be used when you cannot run an RCT. And it eliminates selection bias. And it can combine many variables and make it into one simple score, which is a propensity score. And especially it is useful in situation where the disease you're dealing with is very rare and the experiment itself is very costly or time consuming. Now, the disadvantages, you are only accounting for the variables which you think are confounding variables or confounding factors. All the other variables which is unknown to you will be unknown in the analysis. And only a full match data set can be used. So any missing variable, the entire data gets deleted from the analysis. And you can only compare one group with the other group. Multiple group comparison is not possible in the statistical method. So in this paper, they have taken 11 different covariates, which they have identified as confounding variables. And these were used to create the propensity score. The only catch in this is the propensity score should be matched between the non-DFMO and the DFMO arm, provided that patient should be matched in the amplification status. That means a non-NMIC amplified will not be matched with an NMIC amplified patient, even if the propensity score is the same. That is the only catch they have given in this paper. So that is explained in this slide. Now, this is the consort diagram. So finally, we actually ended up comparing not the entire patients. We ended up comparing only 90 patients against 270 patients, 90 in the treatment arm or the DFMO arm, and 270 in the non-DFMO arm. So let us now go to the demography. So these are the demographic characters in each of the group. So they have explained in detail like the matched cohort and the non-matched. Both the demographic details are explained here. But if you can go through the lines, you'll understand that the ratio of the numbers is almost matched in both the data set, in the matched group and in the non-matched group. This is in relation with the INSS staging, the MIC amplification, the histology, and the pre-ACT response. And this is the response to therapy and how many therapies and the immunotherapy given. Finally, we'll come to the survival estimate in this. So in the overall group, which is non-matched, the entire group when they've compared, the 4-year EFS and the 4-year OS in the DFMO group was 84% and the 94%, which is significant. And in the matched cohort or the propensity matched cohort, the values are actually the same. 4-year EFS in the DFMO group is 84% and 4-year OS in the DFMO group is 96%, and the significance is retained statistically. Now the additional thing, just to complicate a bit, is the sensitivity analysis. So in every propensity score match analysis, sensitivity analysis is performed. This is to validate the data further or to improve the robustness of the study. So what they do is, apart from the co-variables they have taken, like, you know, that this paper took 11 different co-variables. So apart from that, the other factors, like other potential biases are considered, and the data is filtered out again. For example, if you think that the treatment, the time period of treatment is influencing your outcome, you want to know whether the survival status you have done for the propensity match score will hold true when you're considering the patients treated only during that particular time point or the same time point. Then you filter out the rest of the patients who did not get treated at the same time point and take out only those patients who were treated simultaneously. And then we run the analysis again. So such sensitive analysis were performed in this, and it is explained that even when sensitivity analysis for different potential biases were done, the overall survival and the EFS improvement in the DFMO group actually stays same. That is, it still shows that the DFMO group is faring better than the non-DFMO group. Now, to summarize this paper, there is improvement in OS and EFS by adding DFMO to the high-risk neuroblastoma patients in remission after a post-consolidation immunotherapy. This is statistically significant. This is validated by an external control, which is propensity score match, and the same improvement in OS and EFS holds true when a sensitivity analysis is also performed on it. And DFMO has a favorable toxicity profile and can be administered in over a 2-year duration. Finally, I would just like to mention the shortcomings of this trial. One is a bias. So there is potential bias from the unknown variables. They do remain. We are only accounting for the known variables. And also in this trial, in this study, the untreated and treated ratio is taken as 3:1. This can increase the bias to the treatment effect. It is not a 1:1 study. And there are different treatment. It is DFMO improvement in EFS and OS with DFMO holds true for COG based protocols. We don't know whether it will hold true for other known COG protocols. And the benefit of tandem transplant. There are patients in this trial who receive tandem transplant. We don't know how the improvement of survival with the tandem transplant is. We have not taken that into account. And also we don't know whether DFMO will work, or would it work like this in a relapse setting or a refractory setting, or when then there is no remission, or if the bone marrow is still positive. We don't know in those settings how the DFMO would work. Thank you.
Thank you, Anita. I think it was a very interesting session, and the way you explained the statistics, it was a learning experience for all of us. Now, I believe we can ask Dr. Venkat for his comments and what he would like us to take home from this presentation.
Thank you, Dr. Shruti. Thank you, Vasudev. I must first congratulate Dr. Anita for such a wonderful presentation. This is how a journal club should be. Am I audible? Or am I just talking to
You are,
myself?
yes, you are.
I
Yes.
was talking to myself. So just give me 2-3 minutes because there are a lot of residents here and they have to present journal clubs as part of their training, either the fellowship or DNB or DM training. And the journal clubs, I think, if you follow Anita's with the way she presented, I think you should breeze through it. Before even you make your presentation, you are first, you have to choose a topic and you are usually given a mentor, which is a faculty. So discuss a topic which is interesting, which actually helps in changing practice or which is actually implementable in your setting, in our context. But taking a very dry topic on a mouse or a petri dish or a very basic science topic might not be practice changing and might not be useful. And most of your other colleagues and fellows will be sleeping through the journal club if you start presenting very boring research. Try to be very relevant. Having a journal 20 years or 30 years back might not be relevant to the practice. After you choose the topic, read the paper. The first thing is to go through the paper, roughly quickly, just to get a hang of what is happening. And then next is read the abstract. The abstract tells you the meat of the research, tells you what the researchers wanted to do and what they got. And the next thing is that each paper is further divided into an introduction section, a method section, a result section, and a discussion section. And among these two, the methodology and the result section are very important. The methods have to be as thorough as possible. It should tell you if you are planning to do the same study in your place or in your hospital, can you replicate it? It also tells you whether it's been rigorous or not, especially the statistical analysis. Make sure that the objectives are clear in the paper. And if it's a trial, most of the trials, all the trials have to be registered in trial registries. In the US, it's clinicaltrials.gov. In India, it's CTRI. You should try and go back and see, did the investigators change their objectives? Did something change over the 5-6 years? Did they go for looking at something and then they ended up talking about something? This might happen in pharma studies when they're looking at a new molecule and they didn't get what they wanted to look, and then suddenly they change their objectives and they say their drug is blockbuster. So go back and see if there any change. You are allowed to change, but it has to be ensured that it is also reported in the clinical trials registry. Then go through the results. Make sure that they report on the primary objective, which is what they want to see. The other objectives, the toxicities. Look at the graphs and tables. First, see them without reading the text. Try to understand if the graphs and tables are able to explain to you what they mean, what the authors want to say. And then focus on the discussion. One part which many of us actually don't focus is the supplements. So journals have limited number of words. They can have only as many tables or diagrams. So many of the other parts of the research are added as a supplement in a paper. You'll find it at the bottom of the website. And you will find a plethora of information in those supplements, which actually tells you what worked and what didn't work. Sometimes there are things hidden in the supplements which might change your interpretation of the paper. So please go and look at the supplements. And many times, very good studies also have an editorial which talks about the risks, the pros and cons of the study. So have a look at the editorial as well. And just like Anita had presented, keep this slides very simple. We are talking about PowerPoint, not power paragraphs. So in my experience, I have seen people copy pasting the full journal, the discussions, the results into big paragraphs, even without removing the the references. So again, people are going to sleep. So it is your job to understand what the authors are trying to say and put it across to an audience. And at the end, always have a critical analysis. The authors would always say, these are the limitations of a study and these are the benefits of a study. But you should try to find out, as was put by Anita here, that what you think about the study, what are the good points, what are the things where they could have done better, and how will it change your practice at the end of the day? Are you going to go to your clinic tomorrow and start implementing it? So these were the basic things about, a journal club presentation. Now, coming on to this paper, It's a wonderful study. Neuroblastoma, at least in our setting, is high-risk neuroblastoma is very difficult to treat. You are having survivals close to or even sometimes better than acute lymphoblastic leukemia, 95% 3-year or 5-year survival. And we are looking at a 30% survival in India. And yes, randomized control trial would have been ideal. Here you're technically trying to compare apples and oranges, or although you have done a propensity matching to bring the apples and oranges together, but there's always a big risk of bias. And I would be interested to know, because access to antibody dinutuximab is very difficult in this country. Can we use this in a setting without antibody? Does it improve the survival in patients who have not got anti-GD2? That would be very important. And if this drug is not very expensive, it might help us in improving our survival in our context by another 15 to 20%. So very important to do this research in India and other LMICs without where access to dinutuximab is very limited. So those are points. Coming to propensity screen, I just wanted to show you something. The bias with propensity matching. We'll have to unshare.
I've stopped share, sir.
Yeah. Let me just see. I think I'm not able. It's okay. Okay, it's okay. I will kind of put it in the group if others are, and I'm unable to say ask me to quit. I don't want to quit the Zoom application. So that would be something interesting. You can look it up in the internet. If you know, Ozzy Osbourne is a famous. He was the lead singer for a band called Black Sabbath. It's a heavy metal band, and Prince Charles, who's now the head of Great Britain. So both of them were born in 1948. Both of them are married twice. Both of them have 2 children. Both of them are successful in whatever they do. Both of them have like dogs, and both of them spend their holidays. But if you put a picture of Ozzy Osbourne and Prince Charles, they're totally different. One is a heavy metal guitarist, and another is a king of England. So technically, if you're blind, you would think both of them are same. But when you see their photos together, you would realize that they are not, although your propensity matched them. So this is something which you have to keep in your mind when you're propensity matching patients. So that's it. Any other? I think we can move on to the next journal club, or if there are any questions for Anita. There are no questions.
Anita, just one quick question. The DFMO that you said it somehow blocks the NMIC pathway. So was a mutation tested in your in the study, and what percentage were NMIC positive?
Actually, both NMIC amplified and not amplified were taken in the study. So, at least, almost like a 40-55% different percentage was like amplified and not amplified.
So any comparison done between the two?
No comparison were done between like how do they improve in NMIC and not NMIC. That sort of comparison was not done in this particular study.
Okay, thank you, dear.
The other point was, suppose the control arm also did as well as the standard arm. This was a randomized trial and you got 90% in both the arms, because they are contemporary treatments. While you're comparing something which was done a decade ahead, then this drug would have been not been a success because it didn't add anything. So that's also something to remember here, that sometimes control arms don't do the same across trials. You might have in some trials the control arm doing better than others. That's why people say never do cross comparisons. But it would be ideal to do this as a randomized trial in our country without the anti-GD2 and see if it really makes a difference or not.
Thank you, Venkat. Vasudev, please introduce the next speaker.
Yeah, thank you, Dr. Venkat. Thank you, Shruti. So next we have Dr. Shivam Bansal, who is a DM resident from AIMS, who will be presenting on the ALL paper. I request Shruti if you can share his slides because due to some technical reasons he is unable to do that. Shivam, are you there?
Yes, sir.
Yeah.
Very good evening to all. Am I audible?
Yes.
Just give me a
So-
second.
No issues.
Yeah. Are the slides visible now?
Yes.
Yeah. Ma'am, could you? Yeah. So, thank you so much. Can I start? So firstly, I would like to congratulate my colleague from TMH for such a wonderful presentation. So here I come with the hematolymphoid part of our pediatric oncology practice. So which comes to the article which I picked for this particular journal club. Next slide, please. Would be on acute lymphoblastic leukemia. So it was a DCOG study, a Dutch childhood oncology group, which aimed at improving outcomes for ALL by prolonging therapy for the IKZF1 deletion and decreasing therapy for other risk groups. So it was the results of the ALL11 trial, and we'll be discussing about the same and some implications what we can extract from this towards our own LMIC setting and the protocols which we follow. Next slide. So coming to the background of the study, because ALL11 is based upon the ALL10 trial, and ALL10 study by the DCOG group was conducted between 2004 to 2011. That was the time duration. And ALL11 was conducted from 2012 to 2020. And this was the first DCOG study to use MRD as a risk stratification therapy. And the outcomes were good as compared to the previous DCOG trials and comparable to other American trials as well, with a 5-year EFS as 85%, OS 92, and relapse rates of 8%. But there were few important conclusions which they made out of ALL10, which made the basis and the backbone for the interventions planned in the ALL11 trial. So those were firstly regarding the ETV6 RUNX1 group, so the TEL AML1 group, and they found that the relapse rates were like less than 1%. And here became the genesis of the concept of de-intensifying the protocol for the ETV6 RUNX1 group. So that was the first hypothesis which they came up with. Next was regarding the IKZF1 deletion. Now, with regards to IKZF1 deletion, they found that their medium risk group patients, which I'll be discussing later, those patients who are harboring the IKZF1 deletion, they had a poor prognostic value. So they had a poor prognosis. Their outcomes were poor, a 5-year EFS OS, and the relapses were like 23% as opposed to 8% of the same medium risk group, age matched, gender matched, but harboring IKZF1 deletion. And lastly, with regards to Down syndrome, they found that there was a very high morbidity associated with Down syndrome. 8 out of 14 deaths in the induction in the ALL10 protocol was in Down syndrome patients. So again, this led to the concept of de-intensifying the protocol for Down syndrome, which became the basis of the ALL11 study. Next slide, please. So before going further, just a very brief introduction of the IKZF1, and which all of us are aware of. It is like the mutation, which most of them are the deletions. So out of like 100, if you talk about 100 cases, 90 cases would be deletions. And deletions would be encompassing the 8 exons. So there are 8 exons with this particular gene, and which is located on the short arm of the 7th chromosome. And you can find these deletions from exon 1 to exon 8. Few of them, very small number, would be either mutations or gene fusions. And the fusion partners, as shown in this paper, as in this cartoon, it could be STEM, it could be NUTM1, and so on and so forth. Next slide. the important thing to understand with regards to IKZF1 and why does it causes a poor prognosis and what is the reason behind it is because of the downstream signaling. Now, IKZF1 codes for the Icaros, which is a transcription factor, and this transcription factor is crucial for B and T cell lymphopoiesis. Now, with alterations, which are loss of function alterations in IKZF1, there occurs loss of the tumor suppressor function of Icaros. These alterations could be either haploinsufficiency or it could be dominant negative variety. And the standard of care to detect this alteration would be the matrix ligation dependent probe amplification, which is the MLPA test. But when the subclones are very less, which harbor IKZF1, one may need to use PCR to completely rule out the presence of an IKZF1 deletions. So specifically, I'm talking about this fraction is because this was included in the ALL11 study and which was an important measure. Next slide. So the distribution is like among the Philadelphia positive ALL, it is like 66% has been noted, and this is across many studies. And we do have a meta-analysis as well, and by Srinivasan et al. And then among the B other ALLs, so which are Philadelphia negative, there is a major fraction which harbors IKZF1 alteration, and thus detection and particular IKZF1 based therapy would become an important factor to improve the survival for this particular group. So it makes around 15% of the high hyperdiploid ALL, and IKZF1 deletion, it gives the stem cell like phenotype to the neoplastic cells. There is another variety where IKZF1 plus is also talked about, which was introduced by the IBFM study group, where it occurs in association with deletions either in the CDKN2A, 2B, PAX5, and PAR1. We'll be talking about this in detail in the subsequent slides. Next. So this is nothing but the cartoon to describe what I had just summarized regarding the IKZF1. So we need to know that 15% of the B other ALL would have IKZF1 alteration. So it is important for us to identify them because there'll be more chances of induction failure, more chances of MRD positivity, poorer outcomes at both EFS and OS. Next slide. So what this study is all about, the ALL11 trial and this particular research paper, if I talk about, so performed between 2012 to 2020, and the ALL11 study, it's originally an open label multi-center trial and a phase 3 randomized control trial, which was done across 7 DCOG centers. But when we talk about this particular results, which were published in this paper in JCO, we are talking about a study done in a non-randomized fashion. And the eligibility criteria is as shown. Both T and B lineage ALL of between 1 to 19 years were included in the study. Next slide. And this slide shows the exclusion criteria. So what we need to just remember is the secondary ALLs, the relapsed ALLs were all excluded from the study. The pH positive ALLs were excluded from the study. They were enrolled in the ESFAL study group, the European pH ALL study group. Next. So as I told earlier, so the study site included 7 Dutch pediatric oncology centers until June 2018. And after that, the only a single center was taken. The patients enrolled from that single center between 2018 to 2020. And so here I was talking about the reason why we should know about this MLPA versus PCR. So for the quality control measures, they took MLPA and the SNP arrays with having 100% concordance, and a screening modality to detect these copy number aberrations was MLPA as the standard of care, because most of the mutations are deletions. So most of the alterations in IKZF1 are deletions, which are picked up with MLPA. Next. So a small overview of the therapy of ALL11, because this is important to actually interpret the data which they obtained and how we can apply them to our setting. Now, the ALL11 versus ALL10, firstly, they did reduce the cumulative anthracycline doses from 300 to 240. This is quite in contrast to what we are using as the most common protocol in India, being the ICICL. ETV6 RunX1, they eliminated anthracycline from intensification, but anthracycline was still given during the induction period. All ETV6 RunX1 intensification arm, anthracycline was removed. For Down syndrome, from the entire protocol, anthracycline was omitted. But there was a single patient of Down syndrome which did harbor IKZF1 who was treated in the lines of IKZF1 deletion itself. Another thing was regarding poor prednisolone responders. These patient groups who were only PPRs, they were no longer kept in the high risk stratification. They were shifted to medium risk and they were treated in the lines of medium risk. And they wanted to show if their outcomes were similar or they were poor. Radiotherapy was omitted, and with regards to IKZF1, they added one extra year of 6MP MTS. The catch is how exactly this maintenance was added. I'll come in my subsequent slide. Also, pegylated asparaginase was introduced during the induction phase itself. Native Escherichia coli asparaginase was removed, and therapeutic drug monitoring was instituted for all cases to keep a particular target trough levels. Next slide. So this is the standard, the risk stratification, which was similar of the ALL10 and the ALL11. It was totally taken in ALL11 as well, in which standard risk was defined by all these 5 parameters must be present to call it a standard risk, and medium risk having all these parameters. So here you can see that the MRD positivity at day 33 must be less than 10⁻³ At day 33, if it is more than 10⁻³ and by 79, that is end of protocol 1B, if it persists beyond 10⁻³, then only it was taken as the high risk. So you can see that the high risk were actually quite having a very bad biology. They were taken as high risk, either an induction failure or persistence of MRD positivity at 10⁻³ even at day 79 of starting of the therapy, or by the presence of KMT2A rearrangement. Presence of CNS disease or testicular disease was taken as a medium risk therapy arm. Next. Quickly going through the protocol. So this is the main backbone which I have taken from the supplement data. Now, something to note is that all the patients, irrespective of their risk stratification, would receive 1A, 1B, and protocol M. And then they would be shifted as per their risk stratification into various intensification arm. And here, next animation, please. So here, what we can see is that for the IKZF1 abnormality, an extra year of maintenance was added. And those harboring ETV6 RunX1 without IKZF1 deletion, or the Down syndrome without IKZF1 deletion, they received a modified intensification, which was not consisting of the anthracycline. Next. This was the protocol 1A and 1B, and something to note is that all the patients, irrespective of the risk stratification, did receive daunorubicin 4 doses at 30 mg/m². And the protocol 1A and pegylated asparaginase was used. And then with regards to protocol 1B, this is akin to the consolidation protocol which we use as in the ICICL arm, consisting of the 6MP, Ara-C, and cyclophosphamide. Now, I'll be talking about these randomizations a little later. Next slide. So this was the protocol 1A and 1B. Now, protocol M. Protocol M consisted of 4 doses of high-dose methotrexate at 5 g/m², and this was given to all patients. Even the standard risk patients did receive this 4 doses of high-dose methotrexate. This was something to be noted, and with the leucovorin rescue with 6MP ongoing. Next. Now, this is the protocol which was followed for those patients without the IKZF1 deletion, akin to the delayed intensification protocol which is used in the ICICL arm, where we can see that the anthracycline was omitted, and they were continued on the dexamethasone, VCR, methotrexate, and pegylated asparaginase with 6MP. Next. And those harboring these IKZF1 deletions, they were given doxorubicin at 30 mg/m², 4 doses again. Anthracycline was continued. Next slide. This was the extra maintenance. Now, what we can see is this extra maintenance did not harbor a continuous 6MP. It was a 3-weekly 6MP at 100 mg per meter square given for 10 days at a 3 weeks interval. And methotrexate was not given oral, it was given IV and at 200 mg per meter square at 3 weekly interval. What was the rationale of taking this protocol? This was just because another Brazilian study had taken similar maintenance for IKZF1 and they wanted to go safe. It is still a debatable thing if we can continue the similar 6MP oral 6MP methotrexate protocol for IKZF1, but to begin with, they wanted to take that Brazilian study protocol to the IKZF1 patients. So this was the extra maintenance which they added. Next slide, please. So the actual randomization of the ALL11 study, and these were the two randomizations for the asparaginase and the IVIG. For asparaginase, all medium risk patients, they were randomized at day 33 once they are labeled as medium risk. And they would receive either a non-continuous versus a continuous asparaginase, pegylated asparaginase. And this they wanted to study was whether it reduces the chances of silent inactivations or allergy. And this was published in a separate study in a separate blood article. And other randomization was IVIG randomization, where again, the medium risk patients were randomized. Either they received 0.7 gram per kg of IVIG 3 weekly versus no IVIG. And they wanted to assess the reduction in the number of hospitalization. Because these are separate randomizations, we are not discussing them in this journal club. Next slide, please. So the outcome variable for this study, the primary endpoint was overall survival, and the secondary endpoint, EFS, relapses, death in induction, remission, and toxicity. And the event for this study was taken as induction failure, relapse, death, or secondary malignancy. Next. This was the study flow, and the current study comprised of total 819 patients who were then who fulfilled the eligibility criteria, and after applying the exclusion criteria were finally studied upon. And they had a historical control with which they had compared their data, which was the ALL10 study, in which 778 patients were included. Next. And the patient characteristics between the ALL10 and the ALL11 were comparable. And the IKZF1 deletion, as one can see, the deletions were 13%, similar between both the study groups. Next slide. So, sorry for this busy slide, but the outcome. So the primary outcome was overall survival at a long term, that is 5-year. 5-year overall survival, which we can see from the study, was 94%. And 89% was the event-free survival. You can come to the animation next slide. I've highlighted them. And the relapse rates were 8%. Now, this was as a median follow-up of 68 months. And also to note is that you can see that the CR was achieved after induction 1A protocol in 99% individuals. And there is differences between the various risk stratification arms as is expected. So in my next slide, it will be more visible, is this curve. So this is the Kaplan-Meier estimate, which shows that the differences between the high risk, the medium risk, and the standard risk. And here comes the p-value. And the lower part, this shows the censoring. Censoring in each of the groups, and the number of patients who were censored at each time point has been depicted. Next animation, please. And along with this, this is the curve, which looks just opposite of the Kaplan-Meier estimate, which shows the cumulative incidence of relapses. So here also we can see that the cumulative incidence of relapse was significantly higher with the high risk, keeping standard risk as their reference. Now, how did they get to this p-value is the next topic for this discussion. The next slide. We must remember differences between two very crucial tests of interpreting our survival analysis. That is Cox proportional hazard versus log-rank. So what test did they apply to obtain the p-value in the previous estimate which we saw? So it was the log-rank. Both are crucial tests to analyze the survival data. The log-rank test is aimed at comparing between two different groups the survival times. And here we are assuming that there is no covariate present we are assuming it to be absent. Whereas with the Cox proportional hazard, we examine the effect of various variables on the survival time for the particular risk group, such as what is the effect of age, gender, or genetics on the survival outcome of a particular study group. So we estimate the hazard of the event happening, how it changes with each variable. In the next slide, it will be more clear where they actually report their own data and they find that here, which you can see is the age. Now come to the 10 to 14 and the 15 to 18 arm. Here, what you can find is that their event, that is the 5-year EFS, was 81%, 73% as compared to the reference of 92.4%. Now, what test did they apply to ascertain this, interpret this data was the Cox proportional hazard model, and it was a univariate considering single variable into picture. When you consider all the variable, then you come to the multivariate Cox model. Next animation. This is with the T lineage having poorer outcome. Same goes for the IKZF1, in which they found that the 5-year EFS, OS, as well as the relapses were significantly poorer with the IKZF alteration arm. Next. And with the Down syndrome, the number of patients they enrolled, and when you go and read back the study in detail and go to the supplements, they never powered their study to compare the Down syndrome. That was a little bit flaw with the study because it was not aimed primarily to find the differences. And here, as the Down syndrome data, we can see the EFS. Next slide shows the OS, and they did not put a statistical test because it was not actually powered enough to derive some major conclusions out of this. Next one shows the ETV6 RUNX1 data, where they did apply a statistical measure where they found that the outcomes were comparable. Rather, the EFS did not drop and the relapses did not worsen. So next animation, in which it shows the cumulative incidence of relapses were with ETV6 RUNX1 after de-intensification of the protocol. This was proved because of the supportive care as well. Coming to the next slide is regarding poor prednisolone response. So when the patients of PPR were shifted to the medium risk arm, they did not find any statistically significant difference in their long-term outcome, both the EFS, OS, and the relapses. They were comparable. Next is regarding the IKZF1 deletion. So with regards to this, they found by adding one extra year of maintenance did significantly improve the EFS and the relapse rates. OS was not significantly changed by this study, by this intervention, but the relapses had reduced markedly from 23% to 10% after putting one extra year of maintenance. Now, they did another analysis on this. That was, next slide, please, was a landmark analysis. So the time point of beginning this analysis was 2 years of completion of therapy. Otherwise, in the previous slide, what we saw, the analysis was done at the time of starting the therapy. That was the time 0. Here, the time since the landmark point was taken, that was at 2 years. All those patients who were alive at 2 years and who received an extra year of maintenance versus who did not receive as per the ALL10, they were then compared to find whether this extra year of maintenance, did this make any significant difference or not. And here they found that yes, the event-free survival did improve, but the overall survival did not improve. And even the relapses improved from 25% 5-year at 5-year cumulative incidence of relapse. It did come down to 8.8% only. This was to actually see whether any pre-existing therapy did change or this extra year of maintenance did make a difference. Next slide. So the major conclusions was that there was a statistically significant reduction in relapses and EFS benefit with prolonging the maintenance therapy by 1 year. The therapy could be safely de-intensified in these groups, and use of PPR could be negated in MRD guided protocols, which is now an upcoming subject in almost various study groups. Now, the limitations, what I could ascertain from this study, and which the authors did also accept, that it was firstly a historical cohort, and the study was not powered enough to actually draw conclusions regarding the subgroups. The sample size calculation which was done with the primary aim was to ascertain the outcomes of this, the enrollment over 6-year period. So that was their outcome. And these conclusions which we are making, it is not a head-to-head randomized study. What implications we can draw is a little dicey. Now, with regards to IKZF1, we have enough data to suggest that IKZF1 in or in LMIC setting as well did affect outcome, did impart a poorer outcome. Now, adding another year of maintenance would help, but you would need a robust study design in the form of a randomized control trial where you can actually prove it. Here, the study design was keeping a historical cohort. So that was a difference. With regards to de-intensifying protocols, we need to understand that the AL11 was a highly intensive protocol as compared to the protocols which we follow in our LMIC settings. So ETV6 Runexon receiving 4 doses of anthracycline, even a standard risk, so there is a difference. So we cannot draw conclusions taken from this study in our setting, but with regards to PPR, definitely we can consider the negating the effect if we are going to an MRD directed protocols, which is happening. So these could be the major conclusions which we can draw and put it to our own LMIC setting. Thank you. And happy to take questions.
Thank you, Shivam. I would request Dr. Venkatraman to comment on the study first.
Thank you, Dr. Shivam. Again, an excellent overview of a very complicated study, but both the speakers today have been outstanding and have taught us a lot. Like, the flavor of this journal club has been comparing with historical controls to see whether it works, but ultimately what matters is the results of a randomized control trial. And this AL11 trial had asked multiple questions. So they looked at the elastogenase, they looked at IVIG that was presented in last FIOP and did not show that IVIG reduces infection. Then it looked at ETV6 Runx, the de-escalating treatment there, then de-escalating treatment Down syndrome, and prolonging maintenance in IKZF. So basically answering 5 questions in one study. That complicates statistics, that brings in a lot of bias. So usually it's you design a study and power a study to answer one of the objectives, and the other objectives usually are as secondary objectives and hypothesis generating. So to prove this, whether really we need to have an extra year of maintenance, we did it over the years. There is a gradual increase in improvement in survival across all cancers. Maybe that is what happened. Sorry, somebody's in the background. So whether we would bring this to India, we had a lot of debate in our ICICL group, whether to introduce this 1 year extra maintenance in IKZF. We're planning to start doing IKZF in the ICICL 2 protocol, but the consensus was that it's just one study, not a randomized trial, but no historical control. Patients with great difficulty take treatment for 3 years, and then you prolong this by 1 more year. Increased toxicities, especially in maintenance. We have seen patients coming with viral infections. Many of them live very far off. So is it worth it? We don't know. 2 more points I just wanted to make. In Netherlands from 2018, all the 7 cancer centers were merged into one cancer center, which is Maxima. Therefore, from 2018, only Princess Maxima was recruiting. Imagine just one pediatric oncology cancer center for the whole of the country. So every patient who is diagnosed in Netherlands comes to Princess Maxima. And the second point about the anthracycline dose, they had, I think, about 240 or 260 milligram per meter square. ICICL doesn't have that much anthracycline. If you take an intermediate risk, we have 2 doses of Dorno in the induction, which is 50 milligrams per meter square, total dose. And in the delayed intensification, we have 3 doses of Doxo, which is 25 into 375, or a single dose of mitoxantrone. So our anthracycline doses are much lesser compared to the much more anthracycline heavy or intensive protocol. And anthracyclines are responsible for a great degree of sepsis mortality, as has been shown in the ICICL 1 data as well. So yes, whether our children will be able to tolerate such an intensive protocol There's another debatable question because they don't see that much of malnutrition. They don't see that much of multi-drug resistant gram-negative sepsis. I'm not convinced about this extra 1 year of maintenance. This is similar to the pulse VCR dexamethasone. The BFM people showed that it doesn't work, but again, there was a study that IKZF patients might benefit with extra pulse VCR dexamethasone. So would you give pulse VCR dexamethasone versus an extra year of maintenance? We don't know the answer. So this is something you will have to look at. Again, I'm coming back to Journal Club because it's about residents. So when you're looking at a trial, I'll see if I can share my slides now. Yeah, you have something called as Dr. Shivam kept on mentioning about consort. So you have something called as consort diagrams. I'll just show you what a consort looks like. So consort stands for consolidated standards of reporting of clinical trials. Is my screen visible?
Yes, sir.
So when you are preparing a journal club, all you have to do is go to the website. You just type consort in Google, and there's a website called Equator. So Equator gives you guidelines for all types of studies, randomized trials, meta-analysis, you have like the PRISMA guidelines, case reports, cohort studies, control studies. It tells you what are the things which you need to look in a paper, or what are the things which are needed for reporting of a trial. So start with the title, the background, the methods, whether it's randomized, non-randomized, have they mentioned about the sample size? So if you look at this paper, they don't talk about the sample size because they have not calculated the size. And they have clearly mentioned the outcomes, they've clearly mentioned the statistical design. They have talked about the participants who dropped off. So it'll be interesting to see what percentage of patients were able to complete this 1 year of maintenance. Did any of the patients drop off before they maintained? That is where you have to look at the Kaplan-Meier curves. Yes, this is called as informative censoring. And say, for example, you're doing a new drug trial, a randomized trial. And what happens is the drug is too toxic that the patients stop taking it. So if you take 100 patients and 50 of those patients drop out because probably it leads to severe nausea and vomiting and they refuse to take the trial. The other 50 continue on the trial and finish off. They don't have any problems and they do very well. And then the company comes and says that, wow, we have 100% results because they have not included those 50 patients who dropped out of the toxicity. So it's very important to look at the Kaplan-Meier curves to see where is the censoring, if there has been an informative censoring, to get an understanding of the toxicities of a drug. And we need to see what was it. I think Shivam did present in this group of patients as well. So this is almost 25 points and you can go through them and you can have a critical appraisal or analysis of a study to see whether it fulfills all the criteria, whether the authors have managed to address all the queries. And now I just wanted to show you this. This is what I was talking about of propensity matching. Technically, you matched everything, but one of them is a King of England and another is a rock star. So be careful when you're comparing apples and oranges, comparing historical data or comparing, doing a propensity match. There's always a possibility of bias. I think I'll stop sharing. Any questions to Dr. Shubham, or I can take any other questions.
So I don't see any questions in the chat box. Dr. Venkat, in this protocol, they're giving even protocol M high-dose methotrexate to everybody. So that will be a concern in our setup, administering high-dose methotrexate and all the toxicity that happens.
The treatment of ALL is weird. So you have every part of the world doing their own, using mixing and matching. And I think it has to be contextualized. You cannot use what works in the West works in India. So you have to go with your patient profile. So I don't really agree of using high-dose methotrexate. So if you go to the US, they would many people are using Capizis now. And ICICL, we are planning to randomize Capizis versus high-dose methotrexate for all. It's easier for us to give Capizi because methotrexate needs admission. So as long as you're able to get good results with less toxicity, I think that should be the goal. And people will be trying mixing and matching. And in another few years, maybe methotrexate is going to go out. You will have CAR-Ts and bispecifics coming up front in patients, getting it up front. And you might have an era where chemotherapy might become redundant or, not much, no anthracyclines, no methotrexate. Everybody gets Lina, everybody gets CAR-T. So that era is not far away. So we have to go by protocol, but they had some rationale. I'm not sure why a standard risk would need high-dose methotrexate. We have shown that in Icicle 1, they don't need it, and even in intermediate risk. That would be my take.
Sorry, Vasudev, any questions from your side?
No, I think none. Also, I think in the chat box also there are no other questions which are posted.
So I think, as Dr. Venkat said, we would like to congratulate both the speakers. They did a very good job today, and all of us thoroughly enjoyed the session. And I think there is a announcement that Manas has put about the change in timings for the next session, which will be 6 to 7 on 26 September. And I would like to thank Dr. Venkat for his time and effort in, adding his valuable suggestions to the Journal Club today.
Thank you for the opportunity. Thank you, Vasudev and Takesh.
Yeah, thank you, Dr. Venkat, and both the speakers. And I thank the ECO platform also for providing this platform for the national PHO training, and the feedback form is being shared by Manisha. So I request everybody to fill that as well. Thank you and have a nice day.
Good night.
Good night.
Hello. Shashikant. हाँ जी, हाँ जी.